what you will do for a patient who comes to chest pain. بدل ما يصير في عك بالمصرية اللي هو السودانية اللي هو العك ايش انه just doing back and forth troponin, X-ray, consult. It's better to have a clear path what you will do for a patient who comes to emergency with chest pain. It's useful for emergency as well as for OPD, but in general we see them in emergency. 46 years old with chest pain. Anything abnormal you see?
V1, V2,
Maybe. Yeah, maybe there is a ST elevation here.
septal.
For septal leads,
Yes.
right? Okay.
V1, V2.
So remember, if you want to check the ST elevation, this is your isoelectric line. Huh? It's not the PR interval, it is the ST, sorry, not ST, the PT segment. So this is the P, this is the T, this is the PT segment, which we are referring to as an isoelectric line. So you draw a line like this, and this is the J point. So if the J point above more than 2, this tells you there is ST elevation. Also look at the shape of the ST segment. If it is straight or curved, that's something to worry about. If it's coming like this, it's okay, but it's not normal. You need to repeat maybe ECG after some time. So this is maybe a chest pain with this ECG finding. So we are going to talk about diagnostic approach. Remember that chest pain represents about 5% of all ED visits. Then اللي يجي لك اليوم with chest pain, the one who comes to you with chest pain, within 1 year they will come back to you. About 40% of them will come back again to emergency. So it's not only one visit; they will come with recurrent visits. خلينا شوية نروح emergency needs to be assessed risk classification. طيب. The typical symptoms of chest pain is what?
Central chest pain.
Pressure like clenching, typical clenching, radiating to the left, sometimes to the jaw, sometimes to the ears, associated with what? With sweating,
Sometimes
nausea,
sometimes gastritis.
gastritis, they feel like gastritis. Okay, so these are the typical symptoms. But also we have patients confirmed as MI who have chest pain described as epigastric, and also radiating to the right side, not the left side, and sometimes radiating to the short scapula,
Retrosternal.
retrosternal.
And,
That's the typical.
And the interscapular.
Interscapular.
Yes.
So these are all sort of typical presentation, but epigastric becoming more typical. So if you have a patient who tells you I have chest pain radiating to the left arm, many of them are having MI or let's call it acute angina, acute coronary syndrome. But if he tells you that I have chest pain radiating to the right arm, what does that tell you?
It's away from the heart actually.
A phrenic nerve, I think this one sometimes, that's the shoulder
Radiation of the phrenic nerve.
It can.
Commonly they go to the left side radiation, but occasionally goes to the right side. If it tells you that pain is going to the right side, it's more specific. It means that disease is there. While this radiation can be from MI, can be from the lungs, can be from the stomach. So this is non-specific. This radiation is non-specific, but this radiation is more important. If the patient tells you radiation is here, then that's more worrying than radiation here. I'm not saying this is not important. It's important. This happens more frequent, but not specific. This is less frequent, but more specific. Like epigastric pain or atypical presentation, you see it a lot in diabetic, female, elderly. A typical chest pain, يقول لك epigastric pain only. لما آخذ نفس أحس ألم. It's not pain, something wrong here. It's very common in elderly, female, diabetic. Any one of them or combination. بعد لما يكون في ثلاثتهم يعني female, elderly, diabetic, That's the يعني becoming now more frequent than the typical chest pain. Okay, so be very careful with patients who is diabetic, female, and elderly. When they tell you I have chest pain. Now, when they come to you to the emergency with chest pain, you need to have a proper approach. عشان not to, you will not get lost in the workup for the patient. Okay, you cluster your patient to one of three clusters. Definitive acute coronary syndrome, maybe there is acute coronary syndrome or other diagnosis. There will be no other alternative, only three alternatives. Three alternatives we have. First of all, acute coronary syndrome we are referring to, the word acute coronary syndrome referring to what? ST elevation MI, non-ST elevation MI, and unstable angina. This we are worried about. Right? Angina, it was stable angina is not something to worry about now. Maybe later on they can work up in the OPD or the cardiology OPD. So, definitive ACS, acute coronary syndrome, if the patient having chest pain plus ST elevation or new ischemic ECG changes. خلاص, and the patient chest pain and ECG changes, you don't need any confirmation. He's done. He is acute coronary syndrome. He needs to be transferred for proper treatment, which is cath lab, some primary angioplasty, or thrombolytic therapy. So, if he's having chest pain plus ST elevation, the ECG, you don't need any lab test. Diagnosis is ready. Need to transfer. Of course, you will give the initial treatment, which means
oxygen,
aspirin,
okay.
Ladex,
Sublingual,
sublingual or
GTN spray.
GTN,
yeah.
oxygen. Make sure that he is not reaching to more than 95%, because oxygen is harmful for these patients unless they are hypoxic. So give him oxygen only if the saturation is low. If normal saturation, don't give oxygen because it can cause more harm for the patient. So, if it is definite acute coronary syndrome, the plan is clear. And usually these patients should not wait with you. Talk to the cardiologist, give them the initial treatment. They should go with a doctor because they may develop cardiac arrest. So, aspirin, Lavix, control the pain by nitroglycerin, and morphine if necessary for pain. Morphine only for pain, not the treatment. Okay?
We have mnemonics, Oman.
Oman. Oxygen, not for every patient, only if they are hypoxic. Morphine, not for everyone, only if they have severe pain, not resolved by nitroglycerin. But aspirin, Lavix should be all of them, except for those who are allergic for aspirin.
You are statin or not?
No, it's not your worry. That will be somebody else's worry. Okay? Then, you don't need to wait for the lab results. You send the patient with this information to the cath lab in Salada. In the future, maybe they will give you the privilege to give thrombolytic therapy, inshallah. Maybe, معناها he's having chest pain, but ECG is not. The alternative diagnosis, it means anything else other than acute coronary syndrome, meaning dissection, embolism, trauma, rupture, whatever you call it, other diagnosis which might be more lethal than this. It could be just herpes zoster, or it could be muscle pain for whatever reason.
طب احنا ما بنبنيش سيرة تروبونين خالص.
نعم.
تروبونين. بيطلبوهم
Come to
من
that.
الريسك كيوتش.
This lecture is about troponin. This lecture is about troponin. So, you have definite, انت مغمض ترسله إلى cath lab. Alternative diagnosis, you need to work up for every single disease that could be there. From skin, to the muscle, to the heart, to the bone, for everything. Maybe it's acute coronary syndrome, maybe not. So in that case, we have to do workup. وقت عندنا يضيع in this. We are wasting time in this field. طيب? So what we will do with the maybe? We do something called risk stratification. Meaning, okay. So for this type of patient, we do something called heart score. You don't need to remember this. Just remember the name, heart score. You can find it from your application or from your موجود في جوجل. حتى فيها في calculators, online calculator, they can calculate for this for you. طيب, what is heart score? H for history, E for ECG, A for age, R for risk factors, T for troponin. They combine several things to help you to make a decision for this patient. What they found, if the heart score is low, there is the risk within 30 days to develop MI or die from a heart attack is very low. So you can send the patient home without worry. Of course, you should worry about other diagnoses there. Right? And we said three options, right? The one is definite acute coronary syndrome, admit or transfer. The diagnosis malic, another thing, which is maybe rupture, rib or embolism or whatever thing. اللي في النص هو اللي يضيع الوقت عندنا. This is what we are wasting our time. So we'll use the heart score. If the heart score is low, you send the patient home without any worry. If the patient heart score anything more than low, means moderate or high, he needs admission. Admission when? So far will be in the SQH. Right? How to use the heart score? History. If the history is highly suspicious, over radiation or كذا, then this is give them 2 points. Moderately suspicious, you give them 1 point. Not slightly, so you choose one of these three. Either you give them 2 points, 1 point, or 0. Go for ECG. ECG, is it normal? 0. Non-specific, then 1. Significantly as to depression or ECG changes, you think this is something new, then you give it 2 points. Age. Risk factors. Risk factors, you are talking about what? For like what? Smoking. No, alcohol maybe. So diabetic, smoking, obesity, hypercholesterolemia, and maybe family history. So family history, not the patient, father died at the age of MI, at the age of 80.
Young.
No.
Young.
45 and you don't MI, then that's something to worry about.
60 maybe.
No, 45.
45.
Less than 45 and he develop MI, that's a good family history. But if he is age of 70 or 80 and develop MI, that's normal.
Yeah, that will be.
Right? If he has more than 3 risk factors, 2 points, 1 risk factor, 1 point, بعدين هنا no risk factor, 0 points. Troponin. Okay? If it's more than 3 normal limits come 14? 14, 1 4. Right? 1 4. If it is more than 45, you give it 2 points, 1 point, 0. So you calculate this. If it is less than, from 0 to 3, that's low probability for severe illness that will develop within 30 days. Anything more than green is 4 to 6 or more. That means the patient needs to be admitted or transferred to cardiology. What does this mean? Score 0 to 3 means 1.7 MACE. What is MACE? Major adverse cardiac event in 28 days. MACE, major adverse cardiac event in 28 days. Meaning the patient will die or develop cardiac heart attack, myocardial infarction, or stroke within 28 days is less than 1.7%, which is maybe acceptable to send the patient with that risk. But here, if his score is 4 to 6, is 16%, meaning he's going to die or have heart attack or stroke about 16%. So that's why we don't want to tolerate this risk. That's why we admit the patient to the ward referred to SQH. To make this score much more sensitive, more useful, do another troponin. Here we said 1 troponin. Do another troponin. If the first troponin is negative, and after 2 hours we repeat the troponin is also negative, with these things are less than 3, you can safely send the patient home without worry about MI. The risk of MI is less than 0.5%, maybe 0.3%. We're talking about 1, it's less than 1% even. تمام. So that's why troponin we cannot reuse it alone. So troponin has to be used with this. Never ever use troponin alone as a marker, telling you the patient does not have MI or is not going to have MI within the next month. Use it always with this. And to justify why you send your patient home, you have to use heart score. You have to mention how much was that heart score when you calculated for this patient. Yes, that's all for the